Hi there, our highly valued, treasured and esteemed viewers and listeners, and welcome back to your channel of choice. This video I am about to present was compiled by Dr. Nath Arua, a clinical pharmacist by training and profession who is the founder of Progressive Pharmacotherapy Consultants, the premier virtual clinical pharmacy institute for capacity building for healthcare workers. The Virtual Clinical Pharmacy Institute with a difference, where patient safety, medication therapy management and optimal clinical outcomes are very crucial and non-negotiable to us. Here we seek to remain your premier source of crucial tips for high-impact pharmacotherapy services. So, on behalf of the Institute, I humbly urge you all to sit back and spare me part of your very precious time to share with you very useful tips which may prove very, very handy in your line of duty. I now welcome you all to part 522 of our pharmacotherapy series, which majors in renal dialysis. This case refers to patient ROW discussed in parts 520 and 521 of this pharmacotherapy series. Which agents can be used for anticoagulation during hemodialysis in patients with heparin-induced thrombocytopenia, abbreviated as HIT?
But for now, we need some kind of voiceover to drive this. It's always nice to have some kind of voiceover on a how-to video, and you have a couple options. One is you can record one while you're filming, which is a nice way to do it. You can record one after you're filming, or you can generate one.
Heparin-induced thrombocytopenia is reported to occur in 0% to 12% of patients on hemodialysis receiving heparin for anticoagulation. All forms of heparin, including heparin-free, dialysis and low molecular weight heparins, must be stopped in patients with heparin-induced thrombocytopenia. Another class of agents with potential use in patients requiring anticoagulation during hemodialysis is the direct thrombin inhibitors, argatroban and lopyridine. The place in therapy for these agents is in individuals who experience heparin-induced thrombocytopenia. Argatroban is a synthetic derivative of L-arginine, which is approved by the FDA for use in patients susceptible to thrombosis, who also have a history of heparin-induced thrombocytopenia. Most dosage regimens for argatroban consist of an initial bolus dose at the start of hemodialysis followed by a continuous infusion during dialysis. Because it is eliminated by non-renal routes, argatroban dosing in patients with renal failure is the same as for patients with normal kidney function. However, dose adjustments are required in hepatic impairment. Murray and colleagues evaluated 3 argatroban regimens in patients having high-flux hemodialysis. Anticoagulation was more consistently achieved, that is, an activated clotting time longer than 140% of baseline, when a continuous infusion of 2 micrograms per kilogram per minute with or without a bolus of 250 micrograms per kilogram was used. The infusion was discontinued 1 hour before the end of the hemodialysis session. Approximately 20% of argatroban was removed during hemodialysis. Argatroban therapy provided adequate, safe anticoagulation throughout hemodialysis. No thrombosis, bleeding, or other serious adverse events occurred. Another antithrombin product, lopyridine, is produced through recombinant DNA technology. It is biologically similar to hiridine, which is isolated from the saliva of leeches. Unlike argatroban, lopyridine is significantly cleared by the kidneys and by most high-flux dialyzers. The loading dose for intermittent hemodialysis in patients with heparin-induced thrombocytopenia, who need anticoagulation to prevent clotting during dialysis, is 0.2 to 0.5 mg per kilogram, that is 5 to 30 mg, with individualized dosage adjustment based on residual renal function. An activated partial thromboplastin time ratio, abbreviated as APTTR, measured prior to the next dialysis session targeting an activated partial thromboplastin time ratio less than 1.5 and, where available, a leporudin assay targeting a therapeutic range of 0.5 to 0.8 microgram per milliliter are used to guide dose adjustments. An antidote is not available. However, fresh frozen plasma or factor VIIa concentrates can be used if major bleeding occurs. Bivalirudine is a potential alternative for anticoagulation in patients with heparin-induced thrombocytopenia, who are at risk for major bleeding. Among the direct thrombin inhibitors, it has the shortest half-life of 25 minutes in patients without renal dysfunction. Dosing is still being elucidated. A retrospective cohort study of 24 ICU patients undergoing intermittent hemodialysis found that an average dose of 0.07 mg per kilogram per hour achieved an activated partial thromboplastin time goal of 1.5 to 2.5 times baseline values, while bivalirudine infused at a lower rate 1 to 2.5 mg per hour, that is 0.009 to 0.023 mg per kilogram per hour, targeting an activated partial thromboplastin time ratio of approximately 1.5 was reported for patency of the hemodialysis circuitry. Two heparinoids, darnaporoid and fondaparinux, have been evaluated for anticoagulation in hemodialysis patients with heparin-induced thrombocytopenia. However, darnaporoid was withdrawn from the United States, and fondaparinux is currently not approved for hemodialysis. A preliminary study found that fondaparinux can be used as an anticoagulant only in patients using low-flux polysylvan dialyzers. An increased risk of thrombosis occurred with high-flux dialyzers attributed to increased removal of fondaparinux, resulting in inadequate anticoagulation. Further studies are necessary to define the role of this agent in patients on chronic hemodialysis. The next question reads: the dry weight for ROW is 69.1 kg. During his most recent dialysis session, he complained of nausea and lightheadedness 3 hours into the procedure. His diastolic pressure had dropped from 85 to 60 mm of mercury. Ultrafiltration was discontinued, and he recovered without further event. His post-dialysis weight was 69.9 kg. So my question to you is, what are the possible etiologies for his hypotension? In addition to solute removal, the artificial kidney must be used to maintain fluid balance in the patient without renal function. Most patients will become anuric once stabilized on hemodialysis, requiring control of ingested fluids between treatment sessions. Fluid removal during dialysis is then necessary to achieve the dry weight, or weight below which the patient could become symptomatic from volume depletion. Achieving the dry weight is accomplished by ultrafiltration, through adjustment of the transmembrane pressure. The dry weight for ROW has been set at 69.1 kg. Below this weight, ROW exhibited symptoms of orthostasis. Intradialytic hypotension, abbreviated as IDH, can produce a variety of clinical signs and symptoms, including nausea and vomiting, dizziness, muscle cramps, and headache. The reported incidence of hypotension is 10% to 30%, and even higher in patients with specific risk factors, such as autonomic dysfunction associated with diabetes mellitus and cardiac disease. It primarily is caused by excessive fluid removal from the vascular compartment at a rate exceeding mobilization of fluid from the interstitial space. As a consequence, patients with an inadequate hemodynamic response to intravascular volume depletion will exhibit a decrease in blood pressure and other symptoms. An ultrafiltration rate greater than 10 milliliters per hour per kilogram was found to be associated with higher odds of intradialytic hypotension, odds ratio equal to 1.3, p-value equal to 0.045, and a higher risk of mortality, RR, 1.02, p-value equal to 0.02. It may be necessary to adjust the dry weight upward if the patient is volume depleted and symptomatic after dialysis. Other causes of hypotension relate to rises in core body temperature. Sympathetic nervous system activity increases in response to ultrafiltration, leading to vasoconstriction of the dermal circulation and impaired heat dissipation. Increased central heat production can occur during the dialysis procedure. The increase in core body temperature can overcome peripheral vasoconstriction, resulting in hypotension. Excessive heating of dialysate can also produce vasodilation. Cooling of the dialysate to slightly below body temperature may correct this problem, although many patients are uncomfortable and do not tolerate the cooling effect. Eating during dialysis can also cause a fall in blood pressure because of vasodilation of the splanchnic vessels. While food is usually prohibited during dialysis, patients prone to intradialytic hypotension should avoid eating just before dialysis. Antihypertensive therapy before dialysis may exacerbate hypotensive episodes as well. In some patients, these drugs may need to be withheld until after the dialysis session has ended. Immediate treatment of the hypotensive episode can be accomplished by reclining the patient, administering a small, 100 milliliters, bolus of normal saline into the venous bloodline, and reducing the ultrafiltration rate. Several pharmacologic agents have been proposed for the management of intradialytic hypotension, including ephedrine, fludrocortisone, caffeine, vasopressin, L-carnitine, sertraline, and midodrine. Perazella reviewed these agents for their potential use in the treatment of intradialytic hypotension and concluded that only midodrine, sertraline, and L-carnitine show potential benefit in patients. Midodrine is an oral prodrug that is converted to desglimidodrine, a selective alpha-1 agonist. Doses of 10 to 20 milligrams, 30 minutes before dialysis are effective for most patients, but the presence of active myocardial ischemia is a major contraindication. Sertraline is a selective serotonin reuptake inhibitor that has shown promise in intradialytic hypotension at daily doses of 50 to 100 milligrams per day. The mechanism is proposed to be improvement of autonomic function. However, neither midodrine or sertraline have shown additive effects to that of using cool dialysate. L-carnitine has also been tried for treatment of intradialytic hypotension with IV doses of 20 mg per kilogram at dialysis. Its mechanism of action is not known, but it may be related to improvements in vascular smooth muscle and cardiac functioning. However, a meta-analysis of 5 studies examining the role of L-carnitine supplementation for intradialytic hypotension failed to confirm a benefit. An accurate assessment of ROW's dry weight is essential. ROW reports gaining a few extra pounds. If weight gain is related to increased volume, then sodium restriction is needed to minimize weight gain because of fluid retention between dialysis sessions. Another consideration is a change in his lean mass. When questioned about his diet, ROW reports an improvement in his appetite. It is important to consider real weight changes when assessing the dry weight and volume status. Without appropriately increasing the dry weight goal to compensate for his real weight gain, ROW became volume depleted and hypotensive. His dry weight should be adjusted upward to the point at which he no longer is symptomatic, to approximately 70 kilograms. So there you have it, our highly esteemed viewers and listeners. That brings us to the end of this video. If it benefited you in any way, kindly remember to give it a thumbs up, to like it and to share it widely with your peers. Please leave your comments at the bottom, and if you haven't yet done so, I humbly urge you to subscribe to our YouTube channel. I would like to promise you all that the very, very best is yet to come. Thank you very much for viewing this video. On behalf of our senior colleague, Dr. Nath Arua, I sincerely appreciate your partnership, continued support and kind collaboration. We look forward to interacting with you in the next video, which will be part 523.